Welcome to the Briere Deprescribing Guidelines Research Team's webinar, Non-Pharmacological Supports for Youth, targeted for deprescribing from antidepressants, hosted by Dr. Jadon Webb.
Thank you for joining. This is a presentation where I really wanted to stack a lot of time to discussion, so that works well anyway if you're getting a late start. We'll breeze through some topics here that I think can be used practically, but they're also it's a conceptual idea that I wanted to present to all of you who like to think about these sort of things, to see if this is a useful framework in looking at the treatment of depression, especially in kind of a primary care setting. It's a little bit more aimed that way, but it could also apply certainly to outpatient psychiatric care. And the overall idea here is that we often think of, if you look at a decision tree for treating something like depression, especially in primary care, it often has a bit of a binary dichotomous feel to it, meaning the suggestion is medication, usually like an antidepressant, and or talk-based therapy, something like CBT. And so often other little suggestions, ideas, adjunctive medications, adjunctive treatments are sort of speckled into these decision trees, but at the real heart of it is a binary way of thinking of how to treat depression. That if you have someone, and in this presentation, we'll be sticking mostly with mild to moderate, not something so severe that you obviously need to be in the hospital or getting a specialist consult. This is more primary care levels of depression. For instance, non-suicidal, non-immediate life-threatening. And so when you get these types of cases, again, it really kind of turns into, it's a left or right hand. What am I going to do for you? Am I going to start you on a pill, maybe change the pill, maybe I'll do that once or twice if it doesn't seem to be working, plus or minus some kind of talk therapy, and we'll kind of hope for the best. That's what happens when you're depressed seeking treatment. But it also creates a bit of a conundrum for then what to do for the client who is seeking to deprescribe. Since this is primarily about deprescribing, what do you do then if you have a client who is moderately depressed, got little to no or insufficient benefit from an antidepressant, a medication, and they're kind of not really liking the medication idea. They don't particularly want to go up on it and try things that are even that have even worse side effects. They kind of just prefer to maybe not be taking a pill, but they're not totally happy with where they're at because they've not been cured. What do you do with those folks? Okay, and we did have our 2 learning objectives that I think were sent out. Those should be the same as the ones sent out. It's really being able to identify at a global level, the 40,000-foot view, some of the best non-pharm supports for depression out there. There's way more than talk therapy is the point. And also ways to integrate these into clinical decision trees for treating depression. Now that's a big deal to start building these clinical decision-making trees if you're an administrator or a government person or something like that. So I don't pretend to say we should try to build one of those here in this short presentation, but I'll kind of launch the concept out. Certainly would love to talk about it. Next slide. Okay, so back to my intro. Stuck in a binary world where if you need depression treatment and you go to a primary care doc, it really, again, it's pills versus talk in a lot of systems. Some do integrate other modalities a little better than others, but a lot of systems are stuck with these 2 as certainly their favorite 2, if not the only 2 that they would prefer. Next slide. So again, on the other end of it, if you're trying to deprescribe and get out, well, you're taking an antidepressant, you kind of want to get out of it, or you're not happy with the response. What do? Well, more pills if you're looking for efficacy changes and or talk therapy. So again, we're really constrained here. You're kind of caught in this sort of triangle of options. Next slide, please. So with any talk on adjunctive treatments for depression, I find it's very helpful to orient around just how effective medications really are. And here we're kind of mostly meaning antidepressants, sort of first-line treatments. Because if they're incredibly effective, that really, like if they stood head and shoulders clearly above all the other modalities, then they really do deserve a place on a pedestal and should be considered differently than all the others when you're thinking about what to do next. But if that's not the case, then we may need to rethink our approach. When you look at the literature, the sort of global literature around antidepressant efficacy, it's somewhere hovering, depending on the population in the study, or the meta-analysis, somewhere between a 5 to 20 number needed to treat. And as a reminder, what that means is that you would have to treat between 5 to 20 people with a medication to get one true robust response to it. If you flip that around the other way, kind of do 1 over that amount, what that really means is you have a 1 in 5 to 1 in 20 chance that a medication for depression will actually do something substantial for your client. It's interesting if you think about how that wording could be revised if you were doing full disclosure and talking to a client and they said, is this likely to help me? One way to answer that might be no, the odds are actually highly against it having a true effect beyond placebo, which is an awful thing to consider, but it is just the most honest answer. There's, of course, elegance to how you would want to relay that, but the truth is, more often than not, it's not providing a robust response. And it's the efficacy of a medication also relies heavily in the real world on the patient actually wanting the medication. Like, do they want to take it, or are they just kind of being nice and kind of saying they'll go with it, but then they go home and they stop taking it in a week, or they forget it a lot, which happens all the time. So in the real world, your number needed to treat might even be lower because you have adherence problems also. Not only in the short term, but you can also build up a long-term problem of a patient saying, I've had depression on and off through the years, and all those doctors do is offer pills, and I don't really like them. I don't really know what to do, or I think I'll do something else. So your efficacy really is modulated also by the fact that this is a pill, and not everybody likes that. All that to say, if we could find other options that were anywhere in the universe nearly as effective as this, that were different, and might have different people that like it more than others, like different ideas for approaching depression, I would say that's a very good idea and something we really, really should explore. And that's my reason for looking into this some more with you today. Next slide. Perfect. So this is a slide that I would just normally click through fairly quickly. This is just the text-based version of what we just said a second ago. If you wanted to be really, really harsh about the actual statistics and very sort of black and white in your description of whether it will help, what you would really have to say is, yes, these are things that have high chances for side effects. Some of them can be severe, and it's really a pretty low chance actually that you're going to hit on it. Imagine, though, putting it that way, we almost kind of can't accept that as a society because it just is intolerable to sort of think that that's really the case. And so often we just kind of just don't say that. We kind of go with, you know, these are evidence-based. They have randomized controlled trials to support them. Let's try it, because what's the alternative? The really bad part is, though, that this number needed to treat, this low number is true even when you try other combinations of medications. Like if you try to turn the power up, okay, I'm going to add lithium, I'm going to add an antipsychotic, I'm really going to try to turn the volume up to try to get some efficacy, it's still pretty low. So if you're trying to look for an exit strategy for someone that's depressed and they're stuck and they really don't want pills, but they're really not being treated, they're not feeling good, your options are kind of limited in the most common way of thinking about treatment. Next slide. Again, visual reminder to sort of drive the point home. 2 directions to get to the 2 most common things that we offer to people. Those seeking treatment, those seeking to get out of it. We go talk, meds, some combo, I don't know, or other. Maybe some other idea. So in the next slide, I'd like to jump into some of what those are. I'll take you on a tour of some of the ones I offer in my practice as a psychiatrist that I find a lot of my clients are very happy with, that are all evidence-based. They all have some very intriguing data behind them, and I'll run through each one individually here briefly to showcase them. So the global view of what is possible for your depressed patients is actually way better than a lot of us sort of consciously realize as practitioners, at least for me. It was actually even a little startling for me to put this list together on one page and step back and look at it and realize there's actually a lot of ways to get out of depression that are evidence-based, that are not pills. Meaning if you want to deprescribe, there's a lot of exits to the room. Exercise, meditation, diet modification, using bright light, sleep deprivation, other types of therapies like group therapies, expansion on the therapy idea, and even something like TMS. These are all outpatient procedures, things that have relatively low side effects or none, and so would be something appropriate for an outpatient referral, depending. So go to the next slide. So exercise. We all kind of know in the back of our heads exercise is a good idea for most of our patients, probably all of them, but it's actually specifically evidence-based for depression. It really does work as far as we can tell. And it's incredibly healthy. It's good for you all the way around. So instead of having to worry and fret about the possibility of side effects, we can dream about the positive health benefits that are likely to come from it, in addition to being a good depression treatment. So it's sort of a flip on something that you take that may give you nausea, but at least it helps with your depression, to helps with depression and also may change a ton of other things about your life. May help you find a new social group, may help you live longer, may help reduce a lot of your cardiovascular disease risks. I'm just showcasing there's a lot of studies that have looked into exercise. It looks like overall the best reviews, the best large meta-analyses show clearly that it works, and it works with the same general effect size that something like talk therapy or meds do for depression. It takes a few weeks though. There's a delay to it. You don't necessarily immediately get out of depression because you start it. So there is if you have someone who's depressed and has low motivation, there can be a motivation problem. You need to go work out for a pretty good pace, get your heart rate up each day. So what I found in my practice that I do as a practical matter is to think of it as a different referral. If the patient is interested in exercise as a way out, a preferred way out of depression, then let's get them linked up with a personal trainer or a gym that is good at kind of keeping people in a good program. Just the same way, if we were wanting someone to start talk therapy or do cognitive behavioral therapy, we wouldn't just say, go to the library and find a book about it and see what happens. Much better is to say, I know a good therapist. Here's their name and their phone number. Why don't you go give them a call and see what you can work out? So maybe one possibility in your clinics or in your own practice is to have that little list. For those whom you want them to exercise anyway, they're complaining about depression and they seem amenable to this as a way to help them. The fastest way to get that adherence is say, here's somebody I know, or two names that I know so you can compare them. They're great trainers. That's what they do. They try to help keep you motivated, keep you in the game so that you can get better, and this is definitely evidence-based. So that would be one example of another very healthy potential way out of depression. And next slide, please. So meditation also turns out to be very good for depression and anxiety. So if you have both together, it's very good at that. It's healthy. It's good for your mind. Probably does a lot of has other physical benefits, lowering blood pressure and so on. There was a good review, good meta-analysis that I cited here in the middle of the slide that showed a 7-fold increase in remission from depression compared to controls when they engaged in an active meditation program. That's actually pretty amazing if you think of it. That's actually a very large effect. That's something that a lot of pharmaceutical companies would pay billions to get as a result for one of their medications. So you're talking about something that has very, very good effects in the literature. And so breaking that down to something practical, if you're in the right part of the country, you're in the right area where there might be meditation classes, do you know where they are? And do you know a good guide? Maybe someone that's pretty good at this, that has a good reputation, so that you can quickly, in the span of a fast visit, run the list of possible ideas. And if somebody really seems to jump at meditation, give them a meditation referral. That's actually a really good move for their health and for their depression. Next slide. Dietary modification. So this is something that caught me a bit by surprise over the past couple of years, of how effective it is for depression specifically. We know that successful diets that aren't fad diets can make you feel better overall. They can be very good for your health if they're done appropriately. But there have been some new studies. There was one called the SMILES, which is a very big study, 166 subjects. It was done very well, or was well set up, showed a very large effect size on depression when people simply engaged in a dietary consult without necessarily losing weight or necessarily succeeding in it, so to speak. It wasn't required that you had a positive outcome, like a change in how you looked. It was simply that you participated in it. And when that happened, remission occurred in 32% of people versus 8% in the controls. It's a huge effect. And so I put at the bottom personal trainer. I don't know why, because that is not dietitian. So we'll say dietitian. If you have a good dietitian, I have a dietitian. I went out of my way to find dietitians in my area that I like, that I've talked with, that are good with people and good with working with depressed clients. And it's been a wonderful experience. I've actually had a lot of clients who clearly are already leaning towards the diet side of things anyway. They kind of wish they could do it, but their primary complaint is depression. And I will absolutely give them a referral to that dietitian. And I'll call the dietitian and say, I actually think that by working together, they may get healthier, and this may even help with their mood. And I've experienced positive results myself, just in terms of seeing how my patients do. And the literature is rapidly growing in support of that. So again, practical step you can take right out of the gate is to go find a good dietitian in your area. Next slide, please. Bright light, and especially if you live in an area where you have a long, dark winter, can be an incredibly effective treatment for depression. Most of us know that it's a big deal for people with seasonal affective disorder, i.e. your mood clearly swings in response to the seasons. But what we've found is that a good bright light treatment protocol works for non-seasonal depression also. It just seems to be good all the way around. There was a sort of a blockbuster study that came out in American Journal of Psychiatry in February of this year that did a really good job of doing a light protocol with like a dim light placebo, and followed subjects for several weeks. I think it was 8 weeks. They followed them out a lot longer than they normally do. And they found an obvious huge difference in remission, 68% versus 22% in controls, with really rare to no adverse effects. So basically, bright light is safe, cheap to do. You can make it free if you need to, and it works. It works very well. And so an actual action step, and the way I do it, is I actually have a light box in my office so I can show people what it looks like. That's not always possible in a lot of exam rooms, but I also know right where to go online to some of my favorite light boxes, so I can show patients and say, this is what it looks like. This is how you do it. And you can even now, you want to have a certain light intensity. It's 2500 lux or greater is what appears to be biologically active. But you can download free apps on your phone that measure that intensity. So if a patient says, am I getting enough light to do my little thing in the morning? Well, you can actually use your phone. And the way it works is you want to sit in front of 2500 lux or greater, i.e. morning sunshine, for a half hour each morning. And if you can hold it together for a few weeks, you start to get dramatically better compared to placebo. And once you buy the light box, or if you use the sun, it's basically free. Next slide. Transcranial magnetic stimulation, which can immediately to some sound like electroconvulsive therapy or something that's only done in very scary sort of hospital environments. But actually, TMS, which uses magnets, you're basically holding these really strong pulsating magnets over someone's head, is basically what it is, can be used in an outpatient setting. In fact, for a lot of people, there's minimal to no side effects. It's just maybe a slight kind of tingling sensation. And it's been tested a lot, and the established protocols, there's experimental protocols, but the established protocols definitely appear to work, and in fact are often suggested as a treatment adjunct or even sometimes a standalone treatment for people that don't want to be on medications. And it's often used in cases of treatment resistance. And so this is something that does not require people to go on medical leave for a couple of weeks like it would with ECT or something of that nature. It's something that can be done as an outpatient procedure, and again can be very, very effective, and can sometimes even be a way to bridge people off of medications, because if it works really, really well as a standalone and the medication is not really helping anyway, that's often a reason to bridge off of it. So the action step there is, do you know if you have any TMS practitioners, and if so, how to contact them? Because if it's a quick, you should call these people and check it out, that warm handoff is often how you get the compliance, and that may be exactly what they needed. Next slide. So the last of the modalities I wanted to swing through is a really interesting one called, it's actually sleep deprivation treatment. And this is an area exploding in interest because we finally figured out how to make it work well. Basically what you do is you keep people up for a night or half of a night, depending, and then you slowly reintroduce sleep. You don't let them sleep it off. And you combine that usually with bright light in the morning and or meds. And many people experience complete remission from depression, even severe depression, within days. I do this a lot with my clients, and I've had clients go from really scoring at the max on their depression inventories, suicidal, just incredibly depressed, down to being in full remission within 3 to 5 days. It's an incredible treatment. It's vastly underappreciated. It kind of stayed under the radar because the effectiveness has been hard to maintain. We finally figured out that you have to not nap and not sleep it off and not oversleep, or it totally wrecks the effect. Now, this is something that I'm throwing out partly out of interest because it's an emerging treatment, but it's something that's really interesting and shows where the field is going. And I think you're going to see a lot more of this in the coming years soon, because it's free and it's pretty safe. It's staying up for a night, and it's incredibly effective. I mean, it's more effective than almost all the other treatments that we have. And so if you're on the aggressive cutting edge, I get stuck with a lot of the difficult depression cases. It can be worth having a chat with some of your referral sources and say, do you guys know about this? Do you do it? Is that a thing we could think about? It's partly a way of assessing kind of how cutting edge and non-purely pharmacological some of your referral sources are. So it's a very interesting thing. Expect to hear a lot of it. Wanted to present it your way. I do offer this actively in my clinic, and I know others that do as well. Okay, next slide. So deprescribing in our old binary world, if we kind of swing back to the beginning of the presentation, where it's pills versus talk, other stuff, I don't know, other stuff, where it's kind of the second-rate collection of random possible ideas. It is a little bit depressing. It can definitely feel, I've had a lot of patients come in feeling like they're stuck on pills, but they don't know what else to do. It's, well, if I go off, I might feel even worse, and I've tried talk therapy, and I'm kind of at a standstill there. What do I do? That can make deprescribing, I think, a little bit more challenging because you're kind of stuck with limited options. So next slide. But imagine if our process charts, our decision trees, looked a bit more like this. That in reality, if you're thinking through a deprescribing lens, you have arrows going everywhere. You can go to bright light, diet, sleep, TMS, exercise, talk, and group therapies. There's even other modalities besides this, but these are some of the best tested. In other words, imagine if there was a much more assertive reframe that pills are but one thing in a vast sea of possibilities. They're one among many. They're not the main choice, the head and shoulders above all else choice, and the rest are sort of secondary, keep your fingers crossed. They're simply one of the group. To me, that in my practice is greatly influenced kind of how persuasive deprescribing even sounds. I get a lot of my patients off of meds simply by showing them that there's a lot of ways out. Otherwise, you're not stuck. You have lots of options. And the cool thing about that from a patient-centered point of view is you can then spend more of the time finding out how they would prefer to exit the building of depression, so to speak. How would you prefer to get out of this? Are you more of an exerciser? Are you more of a dieter? Are you into the sort of meditative thing or bright light thing, or do you really want something more medical feeling, like a TMS procedure or something like that? And it really empowers the patient to think about how they want their depression treatment to go. It's not just take this pill, hope you don't have side effects, this is what you got to do. It's sort of pick your way. And not only that, but it even breaks the narrative that the only real alternative to pills is talk therapy specifically, because there are a lot of people who don't really prefer talk therapy. They'll do it, but it's not really their favorite way to work out their concerns. They do far better with an exercise program, for instance, than they might with doing a talk therapy-based program. So there's the qualifier to this, of course, that all changes in medicine are very, very slow. They have to go through lots of committees, lots of thinking and vetting and retesting, as they should, so that we don't make sudden radical changes. But there are not big, wealthy interests behind most of these other modalities, maybe TMS, but the others don't really have strong, big, industry-backed advocates for them. And so you're not going to see the same level of studies that have thousands of patients where they've tested it over and over every which way, and then they'll get, at least in the States, FDA approval for the treatment and so forth. And so the one caveat when you talk to patients that I always do is to say these are not tested at the same level as something like Prozac, which has been tested ad nauseum. So it's just something to know that this is not something that has been proved nearly to the same extent. However, my reasoning, my personal reasoning with patients is to just show them that. And if they have good judgment, like if they're not psychotic, is to say, so knowing that, what do you prefer? And if you're not imminently suicidal or extremely depressed, we have a little bit of time to try some things. So why don't we try the one you like the best? You like diet? Let's give it a try and let's keep checking in with each other and see how it goes. And that way, if you suddenly get a lot worse, we can reroute and go to something more medical if we need to. But in the meantime, maybe this will work out for you. And so to me, that's also a more fully informed consent of all that is possible. In other words, I'm not going to pretend that the same level of study data is found for all of these, or that any one of them is guaranteed to work. None of them are guaranteed to work. But that's also true of pills, because if we go back to our number needed to treat discussion, in a lot of studies and a lot of reviews, your chances of actually being substantially helped over placebo from a pill are often on the order of 1 in 10. So sometimes I'll bring that into the discussion also to say rejecting the pill is not the same thing as saying I'm going to get rid of the thing that would probably have helped me. It's more saying I'm going to have to sort of play the slot machine, kind of pull the lever anyway. Which one would I rather pull and try first. And I found a lot of success with that. I think a lot of patients actually find that very relieving. It keeps us away from being salespeople I have nothing against Big Pharma. They've developed some good stuff. They've developed a lot of excellent treatments. Nothing against them, but it does kind of keep us away from that narrative that we're sort of their frontline salespeople. When I am able to lay out 10 ways that my patient can help themselves, that I think makes them feel very empowered because they know they have options. And if they indeed choose to stay on a medication, elect not to deprescribe, or elect to try a pill for the first time, I actually consider that a much more informed consent process anyway. They know the options. They chose this one. Anecdotally, that seems to work out better anyway, because now they've really seen, I chose this out of the whole group. I may as well give it a fair try. I'm not being talked into it. So I think you can win all the way around this way. So in terms of practical practice pointers, if you're a practitioner attending this talk because you want to change your practice, looking at getting a cheat sheet of where to send people for each of the evidence-based treatments is really the way to go. You like exercise? I know a great person. Give them a call. Diet, great, easy way to go here. So that's a practical, easy step you can take, even in a busy practice, to quickly help patients. I have printouts also on like a journal article or some kind of good article that talks about it, the pros and cons and the evidence for it. I'll often give that to patients as well to say, if you want to go read and think about whether this is a good idea, here's where you look it up. And I think that actually works even in a very busy workflow. In terms of if you're more of a policymaker or systems designer, and in terms of kind of the spirit of this organization, I think it makes a lot of sense to really be rethinking these algorithms that I think are way oversimplified and place way too much emphasis on a pill with, frankly, a low number needed to treat as kind of the centerpiece, along with talk therapy, as kind of the two central figures in the treatment algorithm, without acknowledging that there's actually a lot that has come into that space in the past couple of years, and that there's really a lot out there that you can do. Because I think that especially if we're thinking in terms of deprescribing, I think it will really help us all to be very clear that you can get out of the building a lot of different ways. In fact, ways that you might actually enjoy. You might really actually enjoy the process itself. And so that's my spiel. I think I have one more slide, just because why not have a conclusion slide?
Is there one more after this one, Jade?
No, that's it.
All right. Well, thank you very much for that excellent presentation, and we're now going to move into our question and answer period. So if anyone has any questions, please post them in the chat window. We'll keep the webinar open a little bit longer since we had a late start, so feel free to post whatever you like, and we'll try to get through any questions you may have.
And I'll be available even after, just because I know we're short on time, so people also are more than welcome to reach out to me afterwards if that's appropriate. I assume it's okay.
Certainly.
Cool.
I'll send out your contact information to the attendees in an email.
Wonderful.
Actually, I have a question, Jane, and I was wondering if you could tell me a little bit more about the sleep deprivation therapy.
Yeah, it's one of my favorite subjects. I was introduced to it a couple of years ago, and it's one of these, why aren't more people talking about this kind of subjects? And what would you like to know about it specifically? What's most interesting?
I guess maybe you mentioned briefly the process of it, of the idea of, say, keeping someone awake and then slowly weaning them back onto sleep, it sounded like. I was wondering if you could get into that in a bit more detail.
Absolutely. The protocol that has been most tried in studies is that you, on day 0, sleep like normal and get up, and then you stay up for an entire night. So you just do not go to bed until a very early time, the following afternoon or evening. They like to say, so I would stay all the way up through the entire night, through the next day until 6 p.m. and no naps, no cheating, and then I sleep for my normal amount of sleep. I don't oversleep. Like the temptation would be, wow, that reminded me of college. I think I'll sleep for 12 hours, to sleep that one off. That breaks the effect. So what the magic sauce, so to speak, is that if you're normally an 8-hour sleeper, then you would sleep from 6 p.m. plus 8 hours. So what is that, to 2 a.m. And then you wake up. So you'll be up in the middle of the night after 8 hours of sleep, and you need good support. This is what makes it not turnkey easy to do. Now you're up in the middle of the night. What are you going to do with all your time? But a lot of people will rent movies. I'll tell them, spoil yourself. Watch every movie you ever wanted. Play video games. It doesn't matter. Whatever you want to do. So people will stay up very late. They'll wake up at 2 a.m. and stay up until shifting 2 hours forward in their sleep cycle, meaning that night they'll go to bed at 8. So instead of 6, now it's 8. And then they'll wake up at 4. Then the following night, they'll shift forward again. They'll go to bed at 10, wake up at 6. And if that's your normal schedule, you stop there. If you need to do it again, midnight to 8, then you would shift again. So the idea here is to not oversleep, but to gradually re-entrain yourself to your normal wake-up time, going to sleep and wake-up time. And then each morning, you want to be in front of bright light for at least a half hour. That seems to accelerate the effect, and often studies have started people on meds around the same time. We don't know for sure that adds anything necessarily, but they just do. It probably has more to do with kind of the ethics of the treatment of depression and the protocol. We want to make sure and do something we know is evidence-based, but that's the typical protocol.
All right, very cool. And, well,
it's amazing. Some people remit within a day or two. So it's like poor man's ECT.
Well, that's very cool. It seems that the question and answer period in the chat window is a little bit empty right now. Seems like we got a lot of silence out here, so we'll keep the door open for another minute or so, and if nobody has any questions, then we'll go ahead and end the webinar.
Sure. Let me see if there's any.
Oh, we do have a question.
Excellent.
And so, how do you recommend stopping an antidepressant? How fast, in brackets?
It's a great question. It depends on the antidepressant and the dose. If you're at an entry-level dose for an antidepressant, there's not much further to go down other than to stop. If you're on a very high dose, there's a lot of people actually trying to work or trying to think through structured guidelines for getting off of these. But there are so many variables. There's the dose, there's the half-life. If it's a faster half-life elimination, the withdrawal effects tend to be worse. And also the type. Some of the SNRIs, like Effexor, for those that have had experience with that, tends to have terrible withdrawals, whereas some of the SSRIs really aren't that bad. And some of the oddballs, like, say, mirtazapine, really don't seem to have any for a lot of people. So it's hard to give one easy recommendation. What I often do in the real world is actually ask my clients, have you ever forgotten to take it for 3 or 4 days? No judgment. It's actually really helpful if you have. And a lot of them will actually admit, yeah, I do. Yeah, I totally left it for a weekend. How did you feel? Because some will say, oh, I got those brain zap things. It was horrible. Well, now we know we're going to have to come up with a very, very slow taper, where some people say, oh, I forgot it for a week when I went away. I barely felt it. In that case, you could probably just stop, because they've already told you how they're going to feel. Now, if they haven't, if they have no idea how that's going to be, I will often just try and experiment, ratchet down to one dose below. Like if they're on 40 milligrams of Prozac, let's go to 30. And then tell me how that felt. Did you feel any kind of jolt when you went down? Because that gives me a rough indicator of how sensitive they are to a decrease. Like if they really felt awful just from that minor decrease, I know I have to go very slowly. But if they said, oh, I went to 30 and then 20 and didn't care at all, then all right, you probably just go off. It's not as scientific as it should be, but it's basically doing a safe test. Try a safe test and see how they feel.
All right. Well, it seems like that is it for our questions for now. Oh, wait, we have one more.
Oh.
Are there any good resources for patients that can provide an overview of these therapies so that they can self-advocate for deprescribing?
Ooh, that is a good question. I have not seen anything that I'm totally happy with yet, in terms of really knowing all this stuff. There seems to be some advocacy groups that find chunks of this. A lot of them will recognize that exercise works, meditation, some of the more common ones. So you'll absolutely see websites that can show that. The problem is that for non-practitioners, for a lot of patients, they're not really sure how good of an idea it is to even be self-advocating for this. In other words, they're often not sure if prescribed medications like antidepressants are, I don't know, 5 times more effective than a lot of these other things, but they just really want to try them, or if they're the same in terms of their efficacy. It's hard for them to even know, generally speaking, how equivalent these types of treatments are, and it makes it therefore a lot harder to know how hard you should be pushing as a patient to try to get out of a treatment. Like, am I crazy to be trying to go off of these? Is it like I have strep throat and I'm advocating to go off of antibiotics midway through? Or is this something that is totally reasonable to be asking? There are a lot of websites talking about getting out of meds in general for depression. There's a ton of those, a ton of books about that. But it's very easy for those groups to drift into taking a moment to take shots at the pharmaceutical industry, to really kind of go off on it, and then it can kind of separates itself into being kind of an anti-medicine feeling website, even if they don't mean to be that way. So I often find that I instead, just by having my cheat sheet of 5 favorite ways for me to help with depression, the ones I'm most comfortable advocating for and prescribing, gives the patient permission to talk about it with me. It shows it's safe to have that conversation with me. And then I can steer them to specific answers to the treatment they're most interested in. So I kind of feel it's my responsibility to bring that discussion in. And in fact, I do it for all patients unless it's very clear that they're not interested. Like, I'm here for my med refills. I'm totally happy with them. I really don't want to change anything. Well, okay. Barring that, I always try to have another discussion. I'll usually lead with, are you interested in other ways to address depression? And then kind of go down the list.
All right, very good. And I believe that brings us just to the end of our question and answer period and to the end of the webinar. So thanks to everyone for attending, and thanks to our host, Dr. Jadon Webb. Now be sure to fill out a webinar evaluation while the content is still fresh in your mind. You'll find a link available in the chat window. So recordings of the webinar will be available on deprescribing.org and YouTube, and the Briere Deprescribing Guidelines team has hosted webinars throughout the summer. A link to the recordings of our previous webinars will be available in the chat window, and we'll also send one to you via email. Follow us on Twitter and at Deprescribing, and like us on Facebook at deprescribing.org for regular updates on the deprescribing movement. Once again, thank you all for your attendance, and thank you, Jadon.